Thank you. So I'm actually talking about modelling after stopping TKI therapy. And can we get away with less frequent monitoring than we are currently doing for many of the stopping studies? So we know that the molecular monitoring is very important. Monitoring the BCR-ABL transcripts by quantitative PCR, the recommendations are to monitor at diagnosis and then every 3 months until a major molecular response is achieved, which is 0.1% BCR-ABL, and then every 3 to 6 months. So what we're looking for is this type of pattern, a decline in BCR-ABL over time. So here's showing a plot of BCR-ABL over the first 36 months of therapy, and typically what we see is a very rapid decline over the first 12 months. And ideally, reaching a major molecular response 0.1% at this time is the goal of therapy, and this is optimal. And so this initial 12 months is very critical, as we've just heard, and it sets up the outcome for the patient and what happens in the years to come. So this is exactly what we want to see, this rapid reduction. And modelling, a number of years ago now, back in 2005, a Harvard mathematician, Francisca Maicor, modelled this data. And this rapid decline was found to represent the rapid clearance of the terminally differentiated leukemic cells. So again, this is exactly what we need to see. And reaching a major molecular response at 12 months, as we now know, is critically important for subsequently achieving a deep molecular response, which is 0.01% and below. And as we've just heard and outlined by Jorge, a sustained DMR is critical because it is the prerequisite for discontinuation. And the National Comprehensive Cancer Network have now incorporated into their guidelines very nice guidelines for monitoring patients and when to attempt treatment-free remission, including guidelines for monitoring at the molecular level. And so among their criteria at discontinuation, of course, the patient and clinicians have to have access to sensitive and reliable molecular monitoring. And then their recommendations, their guidelines state monthly monitoring for 1 year, so 12 tests per year. And then this can be reduced to 2 months for the second year and then every 3 months indefinitely in the patients who remain in a major molecular response. And of course, prompt resumption of TKI is necessary to reinitiate MMR. But the problem is, the reason why this 12 months is recommended, it's based on a lot of studies, the treatment-free remission studies, where it is known that most patients will have molecular relapse at 6 to 8 months after stopping. And this is highly consistent with a lot of the studies. And here I'm just showing some of the studies. This is the molecular relapse-free survival over 18 months, highly consistent. And most of the patients had lost their major molecular response by 6 months. But interestingly, not all of these studies monitored monthly over the first 12 months. Some of the studies did have monthly monitoring, but the KID study and even the largest study to date, the Euroski study, monitored monthly for the first 6 months, and then this was reduced thereafter. But again, the outcomes and the results were very similar. So the NCCN have chosen a conservative approach to monitoring. But the problem is, and this was outlined very nicely by Jeff Lipton from Canada this year in a commentary, monthly monitoring can be a substantial burden and inconvenient for both clinicians and patients. One of the reasons is that this frequency of testing is simply not available in countries due to their reimbursement restrictions, such as Canada, where the patients are strictly only allowed to have 4 tests per year. And I've spoken to the people in the lab and they've told me that if they receive 5 tests per year, they have to throw the 5th test away. They're not allowed to test it. And in many countries, patients have to pay for molecular testing. So it's a significant burden for patients to have this additional monitoring. So in some cases, physicians may have been discouraged from approaching their patients to consider discontinuation. And in the worst case scenario, patients may discontinue without their physician's knowledge, and this can lead to suboptimal monitoring. And as I will show, BCR-ABL levels in relapsing patients can rise very rapidly. So this could lead rapidly to loss of a complete hematologic response with the suboptimal monitoring. So we've asked the question, can the frequency of monitoring be reduced without causing any harm for patients who want to stop therapy? And what I mean by causing harm is essentially without a delay in restarting TKI. Now in Adelaide, we're actually very experienced in monitoring patients with TFR, and it's been 16 years since the first patient who stopped TKI was monitored. And this is the patient. This is the plot of their results over the first 27 months. This was a patient who commenced imatinib on 600 milligrams in November 2002. He achieved a very good response by 12 months. But I think everybody in the room now will be able to recognise the time that this patient stopped therapy. It was at 12 months. And at that time, we had never monitored patients who had stopped therapy before, so we did monitor monthly. And we can see that within 3 months, the BCR-ABL values were right back to the baseline level. And again, if we look to the Francisca Michael modelling, she modelled that the average rate of increase after stopping BCR-ABL corresponds to a doubling time of every 8 days. So this is very rapid. It equates to about an increase of 1 log per month. And as we are all familiar with, starting TKI can lead to rapid reduction of BCR-ABL. And MMR can be re-achieved within a few months. Now, in this case, it took about 5 months for this patient to regain their major molecular response because they started at their baseline level. But interestingly, if we look at the slope of decline, the initial slope, there was a bit of a delay over the first 1 month, but after that time, the slope was very similar when the first clearance of the differentiated cells occurred and the second clearance. So very characteristic responses. And again, this represents the rapid clearance of the terminally differentiated cells. And we know from our studies that the BCR-ABL kinetics are highly consistent. And here I've shown 4 examples of the kinetics of the BCR-ABL rise and the fall for patients who are enrolled in the Australian Twister study. Back in 2006, this commenced. Now, the vast majority of patients, when they did relapse, had this very rapid rise. We do know that there are a few patients who may have detectable BCR-ABL, but the values can remain below MMR for long term. So a very characteristic increase in the BCR-ABL. And since this time, we have monitored 7 patients who had this consistent exponential rise. And we found, very similar to the original modelling back in 2005, that the average BCR-ABL doubling time was 9 days. And again, this equates to approximately 1 log per month increase. And if we have a look at the STIM study, 1 log per month increase for patients who relapsed is exactly what they reported. So again, highly consistent results across the various studies. And again, very characteristic and rapid BCR-ABL decline once the patients restart. And importantly, there is consistent rate of decline irrespective of where the BCR-ABL levels start. So even at the patient that I showed previously where the BCR-ABL values were right back to baseline, it doesn't seem to matter where you start on this curve. The rate of reduction is very similar, which means that the time to MMR may be delayed depending on where the BCR-ABL value was at restarting. So there are actually many knowns from discontinuation studies. We know that there are highly concordant rates of molecular relapse-free survival, about 60% at 6 months, 50% at 12 months. We know that the molecular recurrence mainly occurs in the first 6 months after discontinuation, and we know that for most patients the rise in BCR-ABL follows a linear model at relapse, approximately 1 log per month. We know that the time to regaining MMR only takes about 1 to 2 months because most of these patients restart within about 4 weeks after losing MMR. So by taking all of this data, we were able to model the safe minimum molecular monitoring frequency for CML patients discontinuing treatment. And this was published earlier this year in Blood. The lead author here was our PhD student, Narani Shanmuganathan. So what we did was assessed 4 monitoring strategies over the first 12 months. So the first strategy was monthly monitoring. So this is the NCCN guidelines. So all patients would have 12 tests over the first year. The second model, we didn't test at 1 month. We tested monthly between 2 to 6 months and then reduced to 2 monthly between 6 to 12 months. And for those patients who didn't relapse, the number of tests over the first 12 months would be 8 tests. The third model was 2 monthly for the first 6 months and then 3 monthly for the next 6 months. 5 tests for those patients who didn't relapse. And the last model was 3 monthly testing over 12 months. And for those patients without any relapse, there would be 4 tests. And we also included in the model the increased frequency that would be required for those patients who did relapse within the first 6 months, and this model was monthly. Now, we based the modelling, and this was very simple modelling, but we based it on the Euroski relapse rate. So this was 39% in the first 6 months, with a further 7% by 12 months. We also took into account the known kinetics of molecular relapse, which is 1 log per month. We also took into account the increased monitoring frequency that would be required following restart. And this was monthly monitoring until an MMR was regained. And we then took a theoretical cohort of 100 patients and applied the 4 different molecular monitoring frequencies in the first 12 months. And we wanted to estimate the number of tests that would be required for each of these models. So this graph shows the estimated number of tests over 12 months. The red line is the NCCN frequency with 12 tests per year. So for 100 patients, there would be 1,200 tests. And then each of these other curves shows the number of tests that we modelled would be required for these 100 patients after stopping. And for each of these modelling strategies, there would be a reduction. And the greatest reduction was for the Model D, which was testing 3 monthly, where there would be a 55% reduction in the testing frequency. So we next applied this model to real patients. So these were 107 patients that we had retrospectively assessed. These were patients, Australian, who had stopped treatment. And of these patients, 46% did have molecular recurrence over 12 months, and all of these patients regained their MMR at a median of 2 months. And we again applied each of the algorithms to this retrospective cohort, and again each algorithm would lead to a reduced number of tests. So Model A, which is the NCCN, 12 tests for all patients. Model B, there was an average of 7.5 tests, and so on average C, 5.8 tests, average for D, 4.9 tests. But what's really important is to see, would there be any delay in restarting if we used this strategy? And so we predicted the effect of delayed detection of relapse with each of these monitoring algorithms. So for A and B, so A, 12 tests per year, B, average of 7.5 tests per year, there was no delay. For C, where there was an average of 5.8 tests per year, we calculated that there would only be a delay for one patient for 1 month, and this would lead to a loss of a complete cytogenetic response. So perhaps this would mean that this patient would be delayed by 1 month to regain their MMR. For model D, where there was an average of 4.9 tests per year, and this was monitoring 3 monthly, we predicted that there would be a delay for 17 patients, and this would be a 1 to 2 month delay. 13 of these would lose their complete cytogenetic response, and again there would be a delay in regaining MMR. But 4 of these 13, the BCR-ABL value would rise above 10%. So we don't know whether this delay could cause a loss of a complete cytogenetic response. So perhaps model C is the model that gives us the best trade-off. So 5.8 tests per year. So a planned monitoring frequency of every 2 months in the first 6 months, and then every 3 months between 6 to 12 months may provide the best balance between a reduced testing and minimised delay in restarting. So in conclusion, lesson monitoring, monthly monitoring may be possible, and it may be safe under certain conditions. So this means that TFR may be more accessible and cost-effective while retaining the safety net. And it would be really interesting to test this model in prospective clinical trials. So thank you for your attention, and I'm happy to take any questions if there's time.